Hello everyone, my name is Shahid Nazir Mohammed, and I'm going to give an overview of this poster presentation outlining polypharmacy and nephrotoxicity, understanding the problem and prompting early renal screening or chronic kidney disease screening for best practice. And this is an overview of a topic that is a focus that relates really to areas around three across three main disciplines really. There's a focus around nephrology in more ways than one. And then there is a focus around laboratory practices in regarding and relating screening, and where polypharmacy is concerned around the use and the importance of preventing over prescribing of medicines that can cause and prompt susceptibility to nephrotoxic side effects from overuse of specific medication. I'm going to break this down into an overview more of an overview of this topic rather than outlining the analysis, the research focus, and the methodology, results, and analysis. Given that this research was took place across several areas of healthcare, I thought it'd be more important to actually just provide an overview, giving an understanding around definitions, and what this an overview of the topic more generally. So, what is I'm going to start off to provide really an introduction, some introduction to the topic, and some definitions, and of course highlighting some of the main contentions as well. So, what is the main issue? Well, the incidence of comorbidities increases as individuals age, and many people are treated with multiple medications. This is referred to as polypharmacy. Poly means many, and pharmacy means medications. So, the terminology itself can be confusing and perhaps overwhelming to the general public in one way or another, but it's a joining of two words where in essence an over prescribing of those medicines, causing problems to renal physiology, at least in this context that I'm going to provide. So when individuals are prescribed more than two nephrotoxic medicines, and there is literature highlighting between two and five medications, or between 5 and 7, but more than two nephrotoxic medications or medicines, renal insufficiency can result. Preventing overprescription is therefore especially important, particularly for older people who have an increased risk for developing irreversible renal insufficiency leading to chronic kidney disease, or CKD. There was a systematic review published in work by Mohammed in 2020, where he highlights polypharmacy and influence on renal insufficiency in elderly care. That paper, or that publication, highlights this context in a bit more in more depth, and it's a retrospective systematic review. So I would encourage listeners to look at that work to get an overview of this topic in a bit more depth. But the systematic review appraised the influence of polypharmacy on renal insufficiency in older people, and those who are receiving elderly care, and as far as systematic review goes, what that entails is basically where a more in-depth interrogation of literature around the topic is prompted to understand the key the main issues, and how they can be not just highlighted, but how they can be addressed, looking at and getting understanding from literature published by across several journals, and in literature that is published by key main authors, renowned authors who focus on this topic. So a bit more now on polypharmacy and its influence on renal insufficiency. Support for patients with long-term conditions like chronic kidney disease can be ascertained through a variety of mechanisms between healthcare sectors, and from a variety of health professionals. And this can be multifaceted. The use of different medications or prescribed medications, commonly referred to again as polypharmacy, is typical of multi-morbidity, and where multi-morbidity exists, that can lead to multiple medical circumstances. And in elderly care, or in the elderly, is one especially important, because there may be more than one medication to treat a specific either comorbidity or a focus around a specific disease. So where use of polypharmacy may be clinically applicable, it is essential to define elderly who may have adverse risk and poor health outcomes. So adverse events really include kidney prescribed nephrotoxic medicines, whilst other risks include falls, adverse drug reactions, increased and lengthier infirmary readmissions to hospital soon after discharge, and sadly what might result from that is a death in some cases. Individuals with renal insufficiency are at a greater risk of the adverse effects of certain medicines that are cleared from the body or excreted by the kidneys in normal physiology, and the effects of polypharmacy can actually go unrecognized, or can be shadowed by the fact that patients may be prescribed certain medicines to offset offset and obviously monitor and help control certain areas of their health, but because they are prescribed these medicines, that often can go unnoticed with regard to symptoms of renal impairment or insufficiency, and this is because the medications that they are prescribed would do what they are obviously are aimed to treat, but there may be underlying other comorbidities or health concerns that often shadow where renal insufficiency is there, but it can be masked, and so this is why the effects of polypharmacy can go unrecognized, and there hasn't, for example, also just to add, where there are 5 stages of chronic kidney disease, traditionally stages 1 and 2, individuals can have normal renal function, and but still can be susceptible or at risk of having renal insufficiency, and this could be contributable or contributed by the fact of certain medications to prevent renal disease or chronic kidney disease, for example, certain antihypertensives or blood pressure tablets, and for example, those are to treat that very main primary concern, to prevent blood pressure, hypertension, but at the same time there are the effects of these antihypertensives can contribute to a risk of falling into renal insufficiency, not so obviously, and if at stages 1 or 2, then renal function would actually look very normal, and the pathology of the kidneys would also look very normal as well. Renal insufficiency and interventions in elderly is what I want to highlight next. So in one study to investigate inappropriate prescribing, one team actually sought to investigate and explore by getting an understanding of inappropriate prescription of 21 drugs, 21 different medications, usually cleared through the renal system or through renal physiology. In this investigation, 1,304 elderly patients over 65 were admitted into infirmary under infirmary care for 90 days, or just over, to explore prescription patterns or routine and risk of renal insufficiency. The team that did this work highlighted that polypharmacy continues to be an increasing problem in the elderly, and the research informs that there are ongoing issues concerns in and around inappropriate prescribing in elderly care. And just to highlight work has been highlighted in more depth in the paper by Mohammed in 2020, published in the Journal of Kidney Care. And I now want to just talk a little bit about the cost benefit of polypharmacy detection on renal insufficiency in elderly care. This poster presentation it does focus more around elderly care, but it is important to understand that again, that where renal or chronic kidney disease is concerned, it does affect. It doesn't have any discrimination. It affects all ages, all races, all groups. There may be different etiologies or pathology as to why someone might fall into a risk category for chronic kidney disease, and the differences between those who have in younger years, in pediatrics or in young people, versus those in adults and elderly care also differ. So just bear in mind that with that understanding, that should be understood, and also that polypharmacy can be an issue or contention in any of those age groups and different those from different races as well. So in one study, a team they conduct actually a systematic review and a meta-analysis exploring early detection and the cost effectiveness of doing that. So looking at really the benefits or the advantages versus the disadvantages of prevention, detection and prevention of both screening for renal disease early or chronic kidney disease early, but also for looking at smarter ways to prescribe at the right time, really, for those who are at risk and will need, and where patients warrant specific medication to treat health. 12 randomized angiotensin converting enzyme inhibitor or ACE studies in 1,943 patients with variable grades of hypertension and proteinuria or protein leaking took place, the team highlighted that the risk of developing renal insufficiency could be lowered as much as 30% over a 2 to 3 year duration, and in a GP model comprising of a single protein dipstick, so doing a urine dipstick test, number 2 doing a 24-hour requesting patients to do a 24-hour protein urine samples to test the amount of protein leaking within a 24-hour period or duration, and also looking at the start of ACE inhibitors in suitable individuals who fit the remit of requiring these particular antihypertensives. 20,000 people over the age of 50 would need to be screened to avoid one case of renal insufficiency. This is data or research that actually is quite retrospective now, but I highlight it because of the sheer volume of patients or those who would be deemed as at risk or susceptible or at risk, that in this literature where a meta-analysis was concerned, which was conducted, sorry, a big cohort of individuals were recruited to carry out these different parts of the investigation, and as many as 20,000 people over the age of 50 would need to be screened to avoid one case of one case of renal insufficiency. And that's important because it really highlights actually how much it, in areas of primary healthcare there is a focus on making sure that patients are treated well on the one hand with appropriate medication and obviously safe prescribing of medication, and to also in line with that, to ensure that there is a reduced risk of patients having those nephrotoxic side effects to contribute to that can be contributed to renal insufficiency, that is absolutely prevented. But on and that's very important to highlight. But the thing is, on the other side of this is a very important message, and that is to say that a renal disease or chronic kidney disease again is not just something that takes place in elderly care. It can again, there's no discrimination as to how this can be contracted in one way or another. So the awareness around nephrotoxic side effects of specific medications needs to come out more into the public domain, and part of the study by this team highlighted that again, there was patients in this not with one form of, for example, not just one form of hypertension, but various grades of hypertension, and that means that with various grades of hypertension, some patients might need more than one form of antihypertensive, and thus if, for example, everything would be done to ensure that a patient isn't prescribed more than one ACE inhibitor, and nowadays there is actually more being done to reduce the use of ACE inhibitors in one way or another. but in some cases it can be unavoidable. So it's important to have that understanding. I now want to highlight a bit about biomarkers to detect renal insufficiency in line with polypharmacy. So and this focus is now more on the screening and the use of different biomarkers where laboratory practice is concerned. So screening aims to identify early mechanisms of why CKD, chronic kidney disease, is occurring, or renal insufficiency is occurring. So renal insufficiency would occur, or renal impairment, or acute kidney injury is the medical terminology used. That normally is something that gets becomes noticeable in one way or another through detection or screening. And if it's serious enough, then chronic kidney disease does follow. But the important understanding here is that screening aims to reduce the risk of the risk or speed of progression of the disease or the long-term condition. For screening to achieve success, the disease must it must be a major health issue and be defined by a natural history with a detectable asymptomatic period or duration. Number two, have suitable options for early management that improves outcomes. And three, have acceptable and readily available screening interventions. And there, in that regard, there is a detectable there has to be a detectable asymptomatic period or duration, and although the full natural history of progression has not been may not be established, i.e., for example, the extent as to how far back retrospectively the disease actually, or the long-term condition actually started to cause become problematic, that might not be established. There are some well-known risk factors, again, such as type 2 diabetes, hypertension, and various other comorbidities. Now, there's a biomarker called cystatin C, and it's well known in laboratory practice. However, against a traditional biomarker such as creatinine or serum creatinine, cystatin C isn't as broadly used. But it could be used as a biomarker for renal insufficiency, and if glomerular filtration rate declines, the blood titer for cystatin C increases. Serum titers of cystatin C are more precise. In literature, there has been understanding that cystatin C is more precise and actually in some respects more sensitive test for renal function, as represented by estimated glomerular filtration rate or glomerular filtration rate, than serum creatinine. Cystatin C titers titers or levels are less dependent actually on demographics such as age, sex, race, and muscle mass compared to creatinine. Creatinine it is a biomarker, and as mentioned, but it relies on or is used on the basis of an understanding that is a byproduct of muscle breakdown. So measurements of cystatin C, however, alone has not demonstrated superiority to replace creatinine in screening for renal insufficiency, and so at least in regions around the UK, and in work that has been again collaborative in various collaborative with in other works with the renal with the renal patient support group of the RPSG. There is actually a webinar on the YouTube educational channel that listeners or listening to this are more than welcome to get an overview of the different biomarkers. There are at least four in total that can be used in different age groups and population to detect renal insufficiency according to their particular demographic, which in some in more ways than one would be more appropriate than simply using creatinine, which has been long standing and has had superiority for a general renal screening or renal impairment detection over the past 4 decades quite easily. In this, those who are listening to this are more than welcome to check out that presentation on biomarkers and looking at renal insufficiency. That all being said, using cystatin C for dosing of drugs is important in the elderly population, or it has been encouraged to be used in the elderly population. Cystatin C is if laboratory teams and those who have the expertise around a focus around biochemistry or clinical chemistry in laboratory practice, they would know that cystatin C is actually also quite simple to implement and use for analysis and screening. And a robust assay generally, but presently there's been low demand or low uptake of that, and simply because there are the data or the literature around cystatin C has not been representable to warrant its use more on a population level. Larger clinical trials to compare and contrast different biomarkers in cystatin C, including, are needed to explore that very dynamic in more detail. So the role, I now want to just highlight one final point, two final things, sorry. The role of education and health professionals around this, and then implications to practice and research. So around role of education and healthcare professionals, so more educational interventions are required to support best practice. This could be achieved through collaborative working through either face-to-face or online consultations or group consultations with patients being as part of that as well. Obviously, where elderly care is concerned, it may require a carer to be involved at that point as well, and this could be achieved through in various ways. Especially now, where patients in those settings are being encouraged really to do things to have their appointments, for example, through through online modalities, and communication in line with that should be or could be not just focused and proactive, but it should be more patient-centric and bi-directional, and that can ultimately help inform shared decision making, especially where options for deprescribing can be eluded. Deprescribing is another an important subject entity, and really in as much as some patients might be on certain medications for throughout a long duration of throughout a long duration through their time through a particular condition or comorbidity. For example, for those who are on antihypertensives, they may be on them for a very long time, and GPs obviously want to make sure that any other conditions are not going to cause more bring about more of a problem to cause more issues with that with that patient's hypertension, for example, or grade of hypertension, but at the same time, if patients or individuals, again, I'll give the elderly care perspective, if they are on these medications for quite a while, then practice where practice is concerned, and around primary care is concerned, there isn't or has not been a lot of focus really to deprescribe or or wean off or withdraw patients from individuals from these medications. Um, they may reduce the dose of particular medications, but to literature highlights to there in the literature there's various definitions of what deprescribing is, but in generic in from a generic focus, it is where one a medication can has that could be problematic to cause particular side effects. So in case of nephrotoxic side effects or and prompting renal insufficiency, the medication might still be required in those patients. They might still need them, or the individuals might need them, but they are at a reduced dose. And so research has highlighted the importance of more of a focus around deprescribing, but the practice around deprescribing varies across different regions in the UK, and to balance aspects around that. Um, um, for example, pharmacy health professionals do encourage what are referred to as medicines use reviews, and they look at prompting those so that these medications that are high risk for nephrotoxic side effects or renal insufficiency, or that can prompt that, along with other medications. That is one of the main aims of medicine use reviews, that pharmacists are encouraged to practice as part of their ongoing development. So best practice surrounding medicines management actually sees integration between different areas of the the patient journey, and technology can help. Electronic patient records can help, but the educational element around that, where patients are involved, that should still should still be a centric focus when looking at this particular area of healthcare. Um, uh, um, uh, uh, I'm now just going to give a brief really on implications to practice and research. So I mentioned a little bit about medicines use reviews, and I don't want to delve into that too much, but they're referred to as MURs, so MURs and laboratory screening should be implemented for best practice, and normally. If you imagine a case where someone might be at not just at risk of nephrotoxic side effects, but drug overdosing, or someone might be at risk of overdosing, then screening is important in such in such individuals, or uh, in those in elderly care facilities, or nursing or care homes, because of the risk that can the risk that patients might have some of their medications, for example, may be given at wrong time or at wrong times during the day, and there is literature out there to highlight how that has been remedied in part, but there is still that problem as well. Polypharmacy prevention in elderly care still requires focusing in at least where educational element needs to be put in part of the individual's journey, and especially if guidelines continue to prompt medicine use reviews or MURs, and where renal screening can be advantageous. Where prescription of ACE inhibitors or angiotensin II receptor blockers or ARBs exist, potassium, which is in physiological context, potassium is more like a trace element, and required really for myocardial functioning, or for the heart muscle to function and pump blood around the body, and so this should be so that needs to be understood, and potassium should be monitored actually before commencing any particular treatments that can actually be a trigger for increasing potassium, at least within 2 weeks. Literature has highlighted within 2 weeks of after starting the treatment, particular treatment, or after or post when a dose has been increased. So if the initial dose does not work to offset or remedy a particular problem around hypertension, for example, then it's important to actually keep on top for the primary healthcare team, and actually secondary care if patients are seeing professionals in between the two health sectors, that the drug levels or titer are monitored. If not in all cases, laboratory screening is warranted for blood pressure or antihypertensives. There is more of a focus around health professionals who would make sure or look to make sure that there is safe prescribing in that case. But if the patient's creatinine is more than 20%, or it's increased as a result more than 20%, and then that needs to be rechecked, and it needs to be discussed in primary care, and if the patient is between the two health sectors, then definitely they the patient's health professional in secondary care will intervene in some way with primary care health professionals as well. Inability to excrete excess fluid and acid, that becomes more obvious when renal insufficiency has definitely been determined, and ultimately the biochemistry and inability to void urine, for example, and where patients might have anuria, or where they are voiding, but it's not enough to rid of toxins through the blood, toxins through the blood via urine, or oliguria, oliguria and then anuria, where anuria is actually complete inability to void urine at all. Obviously, that compounds general physiology. So whilst I'm not going to draw this overview to a close, whilst renal insufficiency kind of interlocks really with a focus around polypharmacy, or risk of patients being overprescribed certain medicines from certain drug categories, that with the importance of detecting renal insufficiency to prevent chronic kidney disease or end-stage renal disease, that is absolutely an important note to be understood here. And it is important to appreciate that CKD stage 2 is also, it is clinically significant, but it is also underreported. So if you recall, where I mentioned that patients might, or individuals might have CKD stage 1 or 2, but because of the medication and the act of what medications have on physiology, even the CKD stage 1 or 2 would be picked up from laboratory in laboratory practice, because the tests and the investigations that take place in those environments are sensitive enough to do that. In most regions of the UK, and I provide this understanding from a UK perspective more so. The number of patients that fall into individuals or patients that fall into the stage 1 or stage 2, because the renal function or renal function or kidney function would look normal, and wouldn't really warrant any further investigations, at least initially. This is why that's actually quite underreported. So on that basis, education actually around CKD stage 1 and 2, areas around polypharmacy and screening should be should take a premise in one way or another, and should be person-centered, and in that regard there shouldn't be any disparity or inequity or how that is how that is being or should be encouraged. That understanding should apply to any population. I now want to just want to say thank you for allowing me to present this collaborative piece of work, this poster presentation around polypharmacy and nephrotoxicity, understanding the problem and prompting early renal screening for best practice. The poster presentation itself highlights some pilot data. This is a collaborative piece of work between one of the RPSG research interns and myself at the University of West of England. It's again an honour to be able to provide this perspective on behalf of the Renal Patient Support Group. Finally, again, just to highlight that this work can be read and understood hopefully in more depth in a paper publication by Mohammed in 2020, where it was published in the Journal of Kidney Care, titled Polypharmacy and Influence on Renal Insufficiency in Elderly Care, and that looks at a focus on technology and screening, and it's a retrospective systematic review. Thank you for listening, thank you for your time.